Good morning. My name is Cherry K. Smith, and I'm with Family and Consumer Sciences Extension at the University of Kentucky. And contrary to your program, I am not Dr. Ann Vale. She is unable to be with us today, so it is my pleasure to welcome you to our third annual Family Impact Seminar. We began this series of seminars a couple of years ago. It was a mechanism to provide legislators with current and unbiased research on issues that affect children and families. Our hope and our whole purpose behind that was so that information could be used to help make sound policy decisions and encourage policymakers to examine the impact that such policies have on families and children. I am very proud to be a Kentucky native. And as such, I recognize that our state does face some unique challenges. Unfortunately, today, we share with other states the challenge that we're going to focus on, that of reducing child abuse and neglect. So today's seminar focuses on approaches for preventing child abuse and neglect, particularly parenting education programs that have been proven to be effective. So we're really fortunate today to have experts from within our state and also across the country, experts who have worked with child maltreatment. Prior to each of the presentations, I'll introduce the speakers, who will have about 20 minutes to share with you, and then we'll take about 5 minutes for you to ask questions of them. And at the end of today's seminar, we will ask you to take a few minutes to provide some feedback on what you found helpful today and or how we can improve next year. So everyone should have received an evaluation in your packets. And if you need to leave quickly or earlier, you'll find a QR code back here. Fortunately, we have excellent extension agents in the state of Kentucky who can tell me what this is. So if you might want to check with your children or grandchildren if that doesn't mean anything to you. But before I introduce our first presenters, I do want to mention some very special partners that have been instrumental in providing the Family Impact Seminars. We thank, obviously, our University of Kentucky colleagues, President Eli Capilouto, Dean Nancy Cox with the College of Agriculture, Food, and Environment, Dr. Ann Vale, our Director of the School of Human Environmental Sciences, and also the Planning Committee that's made up of Extension Specialists and Extension Agents led by Nelda Moore. And most importantly, however, we are very grateful to be here in this venue today. So we're grateful to the Legislative Research Committee, to our Kentucky legislators and their staff members, the governor's office, his liaisons, and other state agencies as well. We especially appreciate the support of the co-chairs of the Interim Joint Committee on Health and Welfare, Senator Julie Rocky Adams and Representative Tom Birch. It's their support, we believe, is a testament to the importance of evidence-based policy decision-making. So without further ado, I want to introduce our first presenters. Dr. Joanne Linecombe is a senior extension specialist in the Department of Family and Consumer Sciences Extension at the University of Kentucky. She has a master's degree in cognitive experimental psychology and a doctorate in family sciences from UK. She spent more than 3 years working for Kentucky's Cabinet for Health and Family Services as a quality analyst. And during that time, she was directly involved with the evaluation of several projects, all aimed at increasing family well-being. Those projects like parent advocacy programs, the Family Preservation Program, Racially Disproportionate Initiative, and the Kentucky Sobriety Treatment and Recovery Teams. In her current position at the University of Kentucky, she is the project lead for the Family Strengths Program. As such, she works with family and consumer science agents across Kentucky to create a benchmark of family strengths and assess community needs. This examines family processes and community involvement and will help design programs and measure program efficacy. She also currently serves as the director of the USDA Rural Child Poverty Nutrition Center. And sharing that time today, she'll be sharing with Dr. Jay Miller. Dr. Miller is an assistant professor in the College of Social Work at the University of Kentucky. He is dedicated to social issues and community outreach, and that's a passion that he brings to his work as an educator and a scholar. His research and academic interests focus on child welfare, particularly outcomes related to foster and kinship care. He's been involved in many community endeavors, including being the co-founder and past president of the Louisville Association of Social Workers, the founder of the Jefferson County Foster Care Peer Support Program. He was a Doris Duke Fellow at University of Chicago and earned his PhD at the University of Louisville. And having spent time in foster care as a youth, Jay is a proud foster care alum. I welcome Dr. Lankamy and Dr. Miller.
Good morning. Good morning. Okay. I am Dr. Lankamy, and as Cherry Kay mentioned, I am co-presenting with Dr. Miller, who will be coming up a little bit later in the presentation. The title of our presentation is Conceptualizing Maltreatment. What is it and how can we fix it? Now, just to provide you with a general overview before we begin, so you can know what to expect, we will be discussing what is child maltreatment and conceptualizing that, and also providing some key terms related to child maltreatment. I'll be providing some child maltreatment statistics, and then Dr. Miller will discuss consequences of child maltreatment, and then current treatment and prevention efforts, and then follow up with areas for continued growth in Kentucky. We would like for you to be able to take away specific aspects from our presentation. The first is to be able to propose prevention policies. It's important to be able to understand what child maltreatment is. We'd also like for you to be able to recognize the real consequences of child abuse and neglect. And then also, we would like for you to be able to identify promising practices in Kentucky for prevention and treatment, as well as appreciate the need to be able to continue to invest in those promising practices. So what is child maltreatment? Child maltreatment is also referred to as child abuse and neglect. So those terms are often used interchangeably. There are two types of maltreatment: abuse and neglect. Okay. Child abuse is defined as deliberate acts or threats of harm committed against a child. Now, there are three types of abuse. The first is physical abuse, and that's injuring a child on purpose. It can include kicking, burning, hitting a child. There's also emotional abuse, and that's any kind of actions or behaviors that harm a child's self-worth or well-being. And the third type of abuse is often the most unreported, and that's sexual abuse. So those are the three types of child abuse. The next category would be child neglect. And that's really the failure to meet a child's basic needs. And those basic needs can include housing, clothing, providing education, access to medical care, and then also providing the proper supervision to make sure that a child can not be exposed to environments where it may present some dangers. So now I'd like to present some national and state statistics for you. And these statistics come from the National Child Abuse and Neglect Data Systems. Okay. So you'll see here that there was a 7.4 increase in the number of children who received an investigation or alternative response from 2010 to 2014. And you can see that roughly is about 3 million to 348 million from that time period. Now, when we look at Kentucky, we see that there was a 16.3% increase in that same time period. Now, that is, compared to the national percent, that is quite significant. But when you look at some of the trends that's been going on within Kentucky, you'll see some reasons for that number. So in 2012, Kentucky actually modified some of its laws. And so they added some clarification to the types of abuse that needed to be mandatorily reported. And also in 2014, Kentucky implemented a new data system that allowed the Department of Community-Based Services to more accurately be able to log in the reports of child abuse and neglect coming in. So this percent increase may not necessarily represent an increase in child abuse and neglect, but it's more accurately reflecting the child abuse and neglect being reported that's present in Kentucky. Okay, so for this slide, you can see statistics of substantiated maltreatment by type. On one side, you see the national estimates, and then on the other side, you see Kentucky estimates. And you can see child abuse and neglect is often the most reported. And on the national estimates, about 75% of substantiated maltreatment towards children. And then on Kentucky's side, it was 91.3% of children were neglected. And then for national estimates for physical abuse, you can see the figure there, 17% for national estimates, and then 9.6% for Kentucky. And then the sexual abuse, 8.3% for national estimates, and then 4.2% for Kentucky. And then if you add that all up, you can see that over 20,000 of Kentucky's children were maltreated, and that was substantiated in 2014. The next set of statistics I'd like to talk about is child fatalities. Nationally, there was an estimated of 1,580 children that died of abuse and neglect, and that's at a rate of 2.13 per 100,000 children in that national population. What we know from reports is that 3/4 of those children were under the age of 3, and then 80% of those cases involved at least one parent. Now, when we look at Kentucky's statistics, there were 15 children in 2014 that died of abuse and neglect. And that's at a rate of 1.48 per 100,000 children. Okay. And when we look at those reports, we see that 0 of the families of those children that died did not have family preservation services. So next I'd like to ask Dr. Miller to come up, and he's going to talk about the consequences of child maltreatment.
Thanks. Good morning.
Thank you.
All right. So my name is Dr. J. Miller. I'm not going to stand behind the mic, but I am a professor in the College of Social Work. And before becoming a professor in the College of Social Work, I spent a lot of time in child welfare work. I was a CPS worker for a number of years. I was an investigator at the Crimes Against Children's Unit in Louisville, so I was put in the position of investigating a lot of maltreatment. But perhaps most importantly, at least to me, is that I grew up in foster care. So I'm here to tell you that the consequences of child maltreatment are real, and they're measurable, and they're tangible. We can see them. And before I kind of dive into this, because I can tend to get long-winded, and I'm going to make sure that we stay within that 20 minutes, there's a caveat, because when we start talking about child maltreatment and the consequences of maltreatment, we tend to compartmentalize it and say, well, these are the physical consequences and these are the psychological consequences. But everything we know about child maltreatment tells us that that's not the best way to talk about that. these consequences are inherently linked and impact each other. And as such, we need to know that a physical consequence just doesn't stop at being a physical consequence. We have to understand the long-term and short-term ramifications of what this maltreatment looks like. So it's important that we understand that the consequences are uniquely interconnected. So to kind of talk about some of the physical consequences, I know we have some nursing students in the room, so I'm sure that you all have heard or will hear this at some point, since you all are often on the front line of recognizing child maltreatment. We have the short-term bruises, cuts, and broken bones. We all kind of know that. Some of us have seen that. Those are the short-term. But then we get into long-term impacts around abusive head trauma, impaired brain development. There are numerous studies that show that there is a correlation between child maltreatment and long-term health outcomes, which is something that we never really think about, but the evidence is there to suggest that that is true. We talk about consequences, the psychological consequences, difficulties during infancy. Now, all of these consequences will be impacted by the severity and length of the abuse. So depending on how intense it is and how long it goes on and how quick we're able to recognize it, those are the kinds of characteristics that will impact some of these consequences, which include the difficulties during infancy. Poor mental and emotional health, that makes sense. If you're an abused person, you will internalize some of that, and as such, it will impact your mental and emotional health. Cognitive difficulties, social difficulties, and again, hopefully I'm not telling you anything new. These things are well known in terms of consequences. Behavioral consequences, we have a lot of those. Juvenile delinquency and adult criminality. There are studies that show that youth who are abused are up to 7 times more likely to be involved in violent incidents or domestic or interpartner violence. So that's what we know. Alcohol and other drug abuse. There are studies that suggest that youth who are maltreated are up to 6 times more likely to fall into cycles of substance misuse. And then abusive behavior. Again, we tend to internalize and mirror things that we experienced as a child. So these consequences are real in their long term. I think something that often gets overlooked when we talk about consequences, and again, of course, my personal experience with this, is the impact that a placement outside a child's home can have on them. In terms of national stats, at the present time, we have a little over 400,000 kids in foster care. Here in Kentucky, we have about 7,800 kids in foster care. Now, the interesting thing is that for the last 5 years, the federal numbers have been going down, meaning there have been fewer kids in foster care. However, in Kentucky, our numbers have been going up. And there are several plausible reasons for that. And they're not bad, quite frankly. One is mandatory reporting. Is everybody familiar with what mandatory reporting is? Everybody in Kentucky is a mandatory reporter, meaning that if you see abuse, you have to report it. So there's a common misnomer that that's just for medical personnel, and here in this state, that is just not true. And that's a good thing, right? But one of the consequences of that mandatory reporting is that people are going to report. And of course, you're going to see more kids are going to be invested, and as such, the likelihood that kids end up in foster care increases. And I'm a policy guy. I teach policy. I love policy. So to me, a lot of times it gets down to the brass tacks of cost. And in terms of foster care in Kentucky, for kids who are receiving a per diem rate, meaning that most kids who are in foster care receive a per diem rate, it costs us about $74 a day. Or in terms of an average cost per child over their length of stay in foster care, we're talking about over $50,000. And the average length of stay here in Kentucky is about 23.2 months, so a little under 2 years. Another thing that we very seldom talk about is kinship care. Is everybody familiar with kinship care? It's when you're placed in the care of a relative. More often than not, it's a grandparent caring for a grandkid. Nationally, we have about 2.5 million youths who are in some form of kinship care. Here in Kentucky, according to the census in 2010, We had over 100,000 youth who were in a household where a relative was the head of that household. And almost 24,000 of those youth were living in a home where an adult wasn't present. So what that tells us is that here in Kentucky, we have about 24,000 kids who are in the care of relatives. And what we know about how kids end up in kinship care is that a lot of times that is the result of a parent not being able to care for the child, i.e. maltreatment. And in terms of Kentucky, we have one of the highest rates of kinship care in general and grandparents caring for grandkids specifically. Now again, that's not all bad. Part of that is because for years we had a really good system in terms of kinship care subsidies, etc. A lot of those have gone away, so we're starting to see a turn there. So, at the end of the day, when we start thinking about maltreatment, we have a real measurable cost. From 2009 to about 2013, the CDC funded a bunch of studies because they were really interested in the cost of maltreatment and what child abuse and neglect cost us. And it was estimated from several studies that child abuse cost $124 billion with a B dollars each year here in the States. And those are direct costs. So we're not even getting into the ancillary cost of mental health treatment, et cetera, et cetera. We're talking about direct cost. Those same studies talked about the need to spend money on prevention programming, and they found and estimated that for every dollar that we spend on programs and prevention, we can expect to get a $47 rate of return. Now, I'm not a mathematician, but if I told any of you in here that you could invest $1 and get 47 back, that would probably be something that we do. And so what that tells us is that we need to reframe the way that we think about child maltreatment and prevention. And particularly, we need to reframe the way we look at how we spend money on programming. We're not spending money. We're investing money. And there is a real measurable ROR that we can get on those investments. But we have to have a reframe, and that reframe has to be predicated on the fact that we're not spending money, we're investing money. And I don't mean the theoretical investment in our future type thing. I don't mean that. I mean real dollars, and we can see those and we can measure those. So it's important that we start to reframe some of that. So Kentucky is doing several things very well in terms of promising practices related to how we address maltreatment. One of the things is several years ago, under the Title IV waiver program, we started what are called START teams, and they're differential response teams, meaning that when you call a child maltreatment report in to the hotline, there's a different way that we can route that report so that the families get the services they need. The START team focuses a lot on substance abuse. So if you call in and there's substance abuse issues, you get routed to this very specialized START team, and they can go out and investigate and make sure that your family has the services they need. We are seeing some tremendous results from those teams, and we're hopefully trying to expand where they are in Kentucky. Another thing that we're doing is a Title IV up in northern and northeastern Kentucky. Title IV waiver evaluation around testing different family preservation models. A lot of times before kids are removed, we put in services called family preservation, and our two subsequent presenters will talk a lot about that. But those are designed to kind of keep families together. And under the Title IV waiver program, what we're doing is testing several of those models to see which one gets the best outcomes. That's a really innovative thing. Kentucky does a really good job at collecting data. Now we just have to get a little better in how we use data to inform our policy and what we're doing. We have FPP and diversion programs. Different agencies do those. KBC located out of Lexington, 7 counties located in Louisville. There's other areas throughout the state. And then we have the First Step programs. Are you all familiar with those? Kids are born at risk, you get a call, and somebody comes out. And it's really about parenting and education. How can we help you along to make sure you have what you need and understand how to take care of young kids? Because we know, I have a 2-year-old, and it's challenging. So those are some of the promising practices. But we can't stop there. We have to continue to think about how we grow. So we need to think about how to implement and evaluate innovative strategies. I am really into innovation. In child welfare, we have been dealing with the same problems for 100 years. We've been asking the same questions for 100 years. And so we really need to start to reframe and innovate the way that we ask and address those questions. We're doing some of that in Kentucky. We can do some more. Ensure an adequate workforce. This is huge. Talking about not only nursing, but social workers and cabinet workers. No matter how good the programs are, if we don't have the workforce to carry them out, we're not going to see the outcomes that we want to see. Another really important thing is that we need to make sure that the interventions that we are using are culturally appropriate. We like to think that we have a one-size-fits-all, and if it worked here, it'll work there. But I'll tell you, I live in Louisville, and if you drive a few hours and get to eastern Kentucky, those are very, very different places. So an intervention that worked in Louisville and had good outcomes may not do the same thing in eastern Kentucky because the culture is different. So we really have to test and collect data to know how is this intervention work differently. We know that, just to be frank, we'll have some interventions that work a certain way for families of color, and it'll be different for other families. And those are the kinds of things and innovations that we need to get into to really start to understand what works. And then, of course, we need to invest in policies that provide parental education. That is, I think, the key. And a lot of times we don't spend as much time as we should talking about prevention and how we can prevent that first call from being made. We tend to be reactive. But again, there's tangible benefits that we can see if we focus on that investment. So I got my 2-minute wrap-up mark. So that's what we just kind of want to set the context. We're going to hear about some more specific programming endeavors from our next couple of presenters. But that's kind of where we are. And I hope that from today you all take that, number one, child abuse is real. Number two, there are kids in this state today, as we sit in this room, suffering from child abuse. And three, we can all do more. Child abuse is not a someone problem, it's an everyone problem. And as such, everyone has to be involved in the solution. All right? So that's what we have, and I guess we'll have some questions or discussion or...
Yes, we want to give everyone an opportunity to ask questions of Dr. Miller and Dr. Lockman.
Your child fatality, your data, the children that are totally incapacitated in comatose states for the rest of their life, does that child, how is that considered in the statistics? Because basically those children are dead to society, and that is a travesty. A lot of them do not die from the incident.
Yeah.
They survive in an incapacitated way. So, I was just wondering about the statistics. The fatalities seem low, but those children in that group, why is that maybe group not pulled out to where it's got its own value? And that's a lot of times we hear as nurses where the children are saved from the shaken baby or whatever, and they end up in Louisville, and then they end up for years at home, and then we get them in school, which I'm a school nurse, and we have to deal with those. And those children, because of the advancement of medical technology, the children are much sicker and in much more incapacitated states coming to school. So anyway, I'm just wondering about that group.
Well, if you, so you remember a few years ago, like in the Courier Journal, there was that big article about Kentucky is the worst in the country around child fatalities. A lot of people remember that because what it spawned is the Child Fatality Review Board. And I think that what we realized here in the state is that we were counting things a little differently maybe than other states were. So you ended up with someone dying in a four-wheeler accident that somehow we saw as neglect that somehow got counted in child fatality numbers. So I think to your point, I'm not sure exactly how those in like a long-term nursing would be counted. I don't think that they're counted in our current stats.
Yeah.
But I do agree that we need to kind of get in there and parse what those
Because
that
that
stats
also
may be.
does measure the extent of the abuse.
Yeah.
Absolutely.
Yeah. And the cost.
Good point.
Dr. Miller, your comment about the cultural differences
Mhm.
in, do you know of any empirical studies that have looked at that and looked at different ways of doing things there?
So, yes, I mean, there are scores of literature and research that talk about this notion of we know that different families experience maltreatment differently. It shows differently. I remember, like in my CPS days, if you had, we used to kind of define child abuse as if you had a bruise. Well, if you are a dark-skinned kid of color, we might not see that the same way. And so that really started to spawn how we get into this differential thing.
Is there empirical data that's usable on how to address it and how to, the training that we can do that's different a little bit than what we did in Eastern Kentucky?
So, yes, there is. Our next presenter is going to talk a little bit about kind of how we differentiate. But the thing is that we have to know which model we're testing. There are a plethora of different models that people use to address different interventions. And all of those have varying degrees of literature or research data around them. I think the thing that we have to do here is decide, number one, which one are we going to use? And then number two, how do we get to a place to collect data on that? So if we were to ask, so here in Kentucky, between Louisville and Eastern Kentucky, is there a study that says this model needs to be adapted this way here and adapted that way there? No. But there is evidence to say in other places out west or other places, say this is a metro area, this is a rural area, these are how these things play out differently. But it's kind of like you don't know until you do it and test it and find out. But there's evidence to suggest that, but if you're asking specifically for Kentucky, I'm not aware of any of those.
Any other questions, these two?
All right.
Thank you
Thank you
so
much for
very
listening.
Our next presenter is Dr. Daniel Whitaker. Dr. Whitaker is a professor at Georgia State University in the School of Public Health. He's also a division director for the Division of Health Promotion and Behavior. And Dr. Whitaker's research includes intervention and implementation research in the areas of child maltreatment and intimate partner violence. His work has been funded by the National Institutes of Health, the Centers for Disease Control and Prevention, the Administration on Child and Families, and most recently, the Patient-Centered Outcomes Research Institute. Dr. Whitaker is also the director of the National Safe Care Training and Research Center and editor-in-chief for the journal Child Maltreatment. Please welcome Dr. Daniel Whitaker.
One work. All right. Well, thanks very much, everyone, for having me here. I've been in Kentucky one other time, but never to Lexington or Frankfort, so I'm happy to be here. So I was asked to talk about evidence-based parenting programs for the prevention of child maltreatment, and so that's what I'll do. I think I went the wrong way. That is not my next slide. All right, so I'm going to talk about three main things. Number one, what does evidence-based mean? And there are a lot of terms around evidence-based that are being thrown around, so I'm going to tell you as well as I can what it means and what are some of the things you need to think about if you want to do an evidence-based program. Secondly, I'm going to talk about what parenting programs are evidence-based. And third, I'm going to talk about considerations about implementing an evidence-based program. So hopefully you'll have take-home points for each of those things. All right, number one, what is evidence-based? So here I've got a fairly standard definition of evidence-based. So evidence-based is specific techniques or intervention models that have been shown to have positive effects on outcomes through rigorous evaluations. And let me unpack some of this a little bit. So the first thing I want to highlight is specific techniques. Number one, you've got to have some sort of protocol or intervention model or curriculum in order to really to really be an evidence-based program. The deal is, if it ain't specific, you can't evaluate it. And more importantly, you actually can evaluate it, but more importantly, you can't replicate it. And everyone's got a story of the family recipe that nobody could seem to replicate after the owner of the recipe had passed on. In my family, it's my wife's grandmother's angel biscuits. I actually don't know what an angel biscuit is, but there's lore of my wife's grandmother's angel biscuits, and my wife, her sister, and her mother have all tried to make these biscuits, and they never seem to come out right because there wasn't really a recipe. There was a list of ingredients. There wasn't really clear how they were put together, what goes in when, how long you cook them for, and so on. And when you have programs like this, well, we do a little bit of this and a little bit of that. Sometimes we're in there for 2 sessions, sometimes we're in there for 10 sessions. Sometimes they get this, sometimes they get that. Well, how do you reproduce that? And that's really what we're after here. So you need something specific. All right, next highlight here is about outcomes. Programs aren't just evidence-based. They are evidence-based for changing specific things. So you've got to decide what you're interested in changing. Are you interested in changing parenting knowledge? Are you interested in changing attitudes? Are you interested in changing behaviors? Are you interested in child welfare metrics like reports, placements, or permanency status? And if you're interested in those things, when you think about, okay, what's an evidence-based practice or program for that, you've got to look for studies on that. Think about this in medical terms. Things become much clearer when we think about these issues in medical terms. Would you ever say a medicine works for everything? No. So you should never say program is evidence-based for everything. Medicines work for particular things, and sometimes they work for more than one thing, and the same is true of our programs. So in thinking about evidence-based programs, one of the first things, I'm going to come back to this, you have to think about is your outcomes. All right, so the last piece is rigorous evaluations. Now, randomized trials are the gold standard, and essentially, if there are no randomized trials on a study or on a particular program, it's never going to reach that highest level of being considered in evidence-based programs. Another thing to point out here: effectiveness is at a group level. Okay, what that means is not every person in a study is going to benefit, and so if you hear about a particular model. Let's say it's the Safe Care model, which I'm associated with. I'll talk more about that in a minute. And you say, well, we tried that and it didn't work for it didn't work for this family. Yeah, it's not going to work for every family. Just like cancer treatment doesn't work for everyone. The flu shot doesn't work for everyone. No one program is going to work for every individual. So when we say something is evidence-based, we're really talking about at a group level, not at an individual level. Provider opinions, I don't know if there are any providers in the room. Sorry, those don't count. Well, I really like this, and I've seen families benefit. Sorry, that doesn't count in evidence-based. And also satisfaction doesn't count. My families really love the model. Well, guess what? If you show up with a pizza every week, they'll probably like that too. But pizza is not an evidence-based model for child abuse. Okay, so how do we find evidence-based models? You've got 2 choices. One is start reading, get your journal articles and your highlighter, and this is fun to do if you're nerdy and masochistic. You also have to have some expertise in terms of knowing what study designs to look for, knowing what outcomes to look for. So, if you really want to go this route, find yourself a nice PhD program to go into, and you'll be set for life. Okay. The second choice is use a clearinghouse, and there's supposed to be a little graphic under use a clearinghouse. One of my graphics disappeared, but that's okay. The graphic that's missing, of course, is the clearinghouse I'm going to talk about, which is the California Evidence-Based Clearinghouse. But there are lots of clearinghouses that essentially have done all this reading for you. They've gone through the studies, they've looked at the evidence, they've looked at outcomes, and they classify programs as having some level of evidence. So my strong recommendation is use a clearinghouse. I use clearinghouses for when there are areas I don't know about to determine the evidence base. So I want to talk about the California Evidence-Based Clearinghouse because this is where I got a lot of my data from. I've got the website up there for you. If you Google CEBC, it's the first thing that comes up. I really like the California Evidence-Based Clearinghouse best of all the ones you can find because, number one, it's very child welfare focused. So it is about child welfare programs. not about mental health programs, not about violence prevention programs, and so on. So it's really a niche for people in this field. The other thing is programs are listed by outcome. So if you want to know, is this a good, just a program to improve parenting skills versus one to prevent neglect versus one to help placement stabilization, you can look that up. It rates effectiveness and relevance. So effectiveness is on a 1 to 5 scale. 1 is the best, the highest level of evidence. And the relevance ratings are really about was the program designed to be used in child welfare or not? We see this a lot, particularly with mental health programs. The studies were done with populations that are outside the mental health sector, outside the child welfare sector, and then the program makes its way into child welfare. We're not exactly sure how the populations are similar or not. So you can tell, is a program effective? Is it relevant to child welfare? The last thing I love about it is it includes a program description and implementation information. And the last part of my talk, if I don't run out of time, is going to be about how to do one of these programs. What are the things you need to think about as you're doing an evidence-based program, which is just as important as thinking about one. So you can get it all at the California Evidence-Based Clearinghouse. So in terms of the scales at CEBC, again, for effectiveness, there are 1 to 5 scales. 1 is the highest. Gosh, I kind of went crazy with the animation here, didn't I? 1 is the highest rating, so you've got to have at least 2 randomized trials to earn a rating of 1. A program of 5 means your intervention, a rating of 5 actually means your intervention is harmful. So there are no 5s on the California Evidence-Based Clearinghouse because researchers have a way of hiding those results. And we also rate relevance as 1, 2, or 3. Again, 1 being the highest rating, that the program was designed for child welfare families. My advice, if you're looking at the CEBC, focus on 1s and 2s. I want to say one other thing about effectiveness rating. The rating of 3 is promising. To me, promising is maybe one of the murkiest terms in this whole area of rating programs. And I've come to think promising means we haven't killed anyone yet. And we have some semblance of data that shows something in the right direction. Families like it, they're willing to come, providers like it. I would be very careful with programs rated as promising. Some of them are great, and the data are actually better than others rated 3. It's a very broad category. But I would try to focus on 1s and 2s. All right, so what parenting programs are evidence-based? And I'm going to apologize in advance that I'm not going to get into any of the details of any of these programs because I got 20 minutes. Okay, the first thing, remember your outcomes. What is it you want to change? Do you want to change parenting behaviors or parent-child-related factors? Do you want to change attitudes? Do you want to change behaviors? Do you want to change parenting mental health? Do you want to reduce substance abuse? All of those things, as we know, can affect child outcomes and child welfare outcomes. So you got to pick your outcome first. Or again, do you want to change child welfare events like CPS reports, removals, and so on? All right, so the first thing I want to show you is the programs that are rated 1 and 2 on CEBC for general parent training. So these models, there are a number of them. This is one of the largest groups. You see a lot of acronyms there. I think that's one of the most important things to having a popular program is to come up with a catchy acronym. There are several programs that are well supported and a few that are supported as well. Now I'm going to talk in a few minutes about what these programs have in common, but I'll tell you that all of these programs, or virtually all of these programs, are known as a class of programs called behavioral parent training programs. And so they use behavioral techniques to affect change. I will also tell you that nobody knows the exact answer to this, but the percentage of child welfare systems or percentage of families in child welfare who get these programs is probably less than 5%. So we see a number of programs there. I do have a little star by the Safe Care program. I'm the director of the Safe Care Center, so that's an inherent bias that I have in talking about these programs in Safe Care, so don't let me push Safe Care on you. But Safe Care is up there as a supported program. All right, now moving ahead, we have programs that are for physical abuse or physical and sexual abuse. Again, the last presenters talked about types of abuse. When we look at abuse, we see less programs that are evidence-based. So we have the MST model, or multisystemic therapy, is well supported for children with sexual behavior problems. And there are 2 programs that are supported, MST for child abuse and neglect and Safe Care. moving ahead to the next slide for child neglect, we have no well-supported programs. And if you remember Jay's slide, what percent of Kentucky was neglect? 91%. That's a problem. And there are two models that are supported, meaning there's at least one randomized trial. Those are the home builders model and Safe Care. And of course, 91% in Kentucky, 75% nationwide. And more as the rates of physical and sexual abuse have declined over the years, neglect has held steady. So neglect is becoming an increasingly larger percent of the problem. All right. Now, prevention programs for child abuse and neglect. So these are programs that maybe go in before abuse or neglect has happened. We have several that are strongly supported. The Nurse-Family Partnership is a home visiting model that starts before the baby is born. It's for first-time moms only. Cannot be used in a child welfare setting. They don't allow that because it's for first-time moms only. But we also have the SEEK model out of Oregon and the Incredible Years out of Washington as well-supported programs, and a few supported programs as well. I put up there the evidence of no impact. This is very unusual that a program that's rated evidence of no impact, because there actually have to be studies published that show the program does not affect the outcome. And like I said, I'm being facetious, but researchers have a way of not publishing null findings. It's not necessarily that they're trying to hide them. They have a hard time getting those in journals. But there have been enough studies now on healthy families to show the model actually doesn't affect child abuse and neglect. But move over to the next box, and we talk about child well-being. Healthy families is rated as a 1. So it's a strong model for producing well-being in children, not a good model for preventing child abuse and neglect. So this is where you have to be careful about your outcomes. And so, again, we could be here all day with me showing you these little graphs of which programs are 1s and 2s and not really telling you much about them. The point is you can find all this stuff on CEBC on your own. It's very easy to use. The last thing I wanted to show you is these are programs for core child welfare services. And one of the reasons I put this up here is to show you that how little we know. In terms of caseworker practice, so these are the people who go in and do investigations. There are various models now floating around about caseworker practice, and probably the best one is solution-based casework, which is right out of University of Louisville, I think, right? It's only rated as a 3. Again, if I can say this is a good 3, not a bad 3, and the Family Connections model out of Maryland. In terms of family stabilization, reunification, there's no 1s. Home builders is a 2. And in terms of placement stabilization, there's only the multidimensional treatment foster care is rated as a 1 or a 2. So there's very few models for caseworker practice. These people, like Jay was an investigator who go out and actually work with the families. The other models tend to be delivered by community-based private agencies. All right, so I want to talk about some of the common elements of some of the more higher-rated programs in here. So Rick Barth is one of the leaders in child welfare research. He's really argued for a common elements approach. He says, don't waste your money buying one of these named programs. Just do the things in them because they're basically all the same. And I can get on board with that. There are a lot of common elements. One is, I already mentioned, these all use behavioral methods for teaching parents new skills. So it's social learning strategies, social learning approach with behavioral strategies. What does that mean in practice? What does that mean? It means practice in the home. If you have a program that's mostly providing didactic information, it's not going to work. You've got to get in there and show parents what to do and have them practice the skills that you want them to do once you leave. So we need joint parent and child participation. Lots of studies have shown that the best parenting programs involve both the parent and the child together. There's a strong focus on increasing the positive interactions between the parent and the child. And so I think in child welfare we have a tendency to focus on all the bad things that have happened. That's what brings us in. But we know that when we look at these families, there's a real lack of positive interactions between the parents and the kids. So we teach the parents to get on the floor and play with the kids. It sounds very basic, but it actually goes a long way on a number of dimensions. And it really can help prevent the interactions that lead to physical abuse. There's an emphasis on positive reinforcement, not punishment, and behaviors are charted and tracked. There's actually data used in delivering the service. Okay, so that's one of the things that all of these good behavioral models have in common. The other thing I'm going to tell you is that these evidence-based programs, they tend to be short. And this is something that people who work in child welfare are terrified of. I'll just say, sometimes people in child welfare, they hate good news. They hate to hear that we don't need to give the family 65 services. We can just start with one and see how they do. And so one of the things that many people have been advocating for is to shorten services, do focus services that are really prioritizing the problems that families have. And parenting, of course, is a core problem. All right, so the short summary so far, and thinking about, how am I doing on time? 5 minutes left? Okay, short summary so far, thinking about evidence-based parenting, figure out what outcomes you're interested in, use the CEBC to find an evidence-based parenting program. There are lots of good ones, maybe not for the outcomes you're interested in. Fewer in the child welfare domain, and they tend to use the same things. And don't be afraid to be brief. All right, let me talk a little bit about implementing an evidence-based parenting program. This is the area of interest that area of research that I've really gotten into. So what is implementation? What I mean is installing a program into a system. So bad implementation equals poor outcomes, no matter how good the program you have. You know, the use as directed label you get on pretty much everything you buy, the same is true for here, use as directed. Don't let this happen to you. I can't remember the last time I did a presentation without this comic. Dilbert says, I'm back from training, I got a big binder. The training is already forgotten, but the binder will last forever. A living monument to temporary knowledge. Let's admit it, how many of us have been in these trainings? Probably all of us. So why do we need to pay attention to this? Ask yourself a simple question if you work in child welfare. How easy is it to make anything happen? I see you smiling. How easy is it to make anything happen? You know, the answer is, particularly in child welfare, very difficult. It's not easy to get anyone to do anything new. And as somebody who's brought a turkey sandwich for lunch for the last 6 years straight, I'm in that group as well. And it's especially true when you're dealing with a system. So you're trying to get people to do something different. They're part of an organization. The organization is part of a system. And the system tends to respond to crises. The systems tend not to be very planful. So there's lots that can go wrong. So here's a simple implementation framework. So Jay and I were having a great chat before we started the presentations here about you know, possible safe care implementation here in Kentucky, and he's telling me a little bit about the system. So when we think about implementation, we think about stages that a state or a county goes through when they're thinking about a model. So the first thing they do is they do exploration and try to make a decision. So they try to figure out what are the outcomes I'm interested in. Then once they make a decision, there's a preparation phase. Okay, we've got to get things ready. Think about this as planting a garden. Okay, what am I going to have in my garden? Okay, I'm going to have cucumbers and tomatoes. Now I have to till the soil. I have to get everything ready. All right, active implementation is when you start. So this is where most people would think of us. Okay, we're going to have the training, and then we're going to start. But then there's a sustainment phase. Turnover in child welfare, 40% a year, 50% a year in some places. So half the people we train today will be gone a year from today, and you'll be hiring a whole bunch of new people. So at each of these stages, there's lots to think about. So in terms of exploration and adoption, you know, which models address the problems that you want to work with? Which models fit in your system? We've had this a lot, again, as the disseminator of safe care. Lots of people have paid us to teach them to do safe care, and then they realize, oh, we don't get paid for as many sessions as safe care takes to do. What are we going to do? They asked me, what are we going to do about that? And I said, oh, what are you going to do about that? Because that's something you really have to figure out before you go in there. Who's doing the exploring? Is it a state, or is it a county? Is it an individual provider? That matters. Who else needs to be involved? In terms of preparation, this is huge. You have to find the developer and figure out how they do training and implementation support. Who else do you need to involve? If you're an agency, I've got to tell my CPS county because they're the one that sends me referrals, and I want to make sure I'm still going to get referrals. Do your funding models still work? This is what I was just talking about. Who's going to champion the implementation? Who's going to provide leadership? This is huge. We've seen so many implementations die on the vine because there's not a person with leadership, in leadership, who can say, this is now the way we're doing business, and if you don't like it, find another job. How do you get rid of the old models? This is really important. You know, I'll just say if you add a checkbox onto the referral sheet that says new model, and all the caseworkers are used to checking the old box that says old model, they will keep checking the old box. If you want to do something new, you've got to get rid of the old thing. All right, in terms of active implementation, you've got to have client referrals flowing. You've got to collect data. You've got to collect data on how well the models are being implemented, and are you getting the outcomes that you want? A lot of people think, okay, I'll do an evidence-based program so I don't have to collect data on outcomes. The opposite is true. When you do an evidence-based program, you are supposed to be collecting data on outcomes because that's part of the evidence base. It's just like the last presenters were saying, we don't know exactly what works for who, and it's nice that if a research study in Oklahoma or New York found these effects on this population, but things are a little different here. So collect some data and make sure it's working. Sustainment, I've already talked about what happens when people start turning over. What is the model for sustaining that? In the interest of time, I'm going to skip this last slide, and I'm going to say, here's my little summary. Evidence base is a function of rigorous trials. UC-EBC, there's lots of good programs out there. To implement a program, it's a large effort. It's not just a workshop training, or you will end up like Dilbert. The whole system has to be involved, and that's it. Thank you. I want to put in one more plug before I stop. I am affiliated with SafeCare. If you're interested, we have a research study going on that's completely funding training and implementation support. If anyone is in child welfare, I'd love to talk to you about it. Thanks.
Any questions for Dr. Whitaker?
I do have one really quickly.
Yeah.
The Safe Care programs and some of the other program models that you identified, Nurse Family Partnership, and Kentucky's Hands sort of hybrid home visitation system. And we do have Nurse Family Partnership sites
Yep.
in Kentucky as well. The programs that you're talking about, are those for families that are already into kind of secondary prevention situations? Because really,
yep.
that's Kentucky has that gap there.
Yeah.
From the true primary
Yep.
prevention before those children are born, and then
Yep.
for families that are already involved
It-
in some risk.
Yeah.
So
It's squishy, and
it always
to use a technical term.
Yeah.
NFP is very, I guess to their credit, they're very rigid.
Yeah.
First time moms only. If you've got a kid, if you've got a kid, you're out. We don't want you, we can't help you.
And hands in Kentucky
Yeah.
is a little more.
Now, a lot of the models I put up there, the good evidence-based, behavioral-based parenting models, they actually came out of mental health. So they were developed in order to reduce child behavior problems. And, I don't know who it was, but somebody smart came along and said, hey, guess what? All of the parents in our child welfare system could benefit from these. It's the same skills,
Yeah.
okay? So I'll just speak for SafeCare. We've been used a lot in this sort of prevention area where we've got families who are at a very high degree of risk for coming into child welfare, or maybe they had a report,
Right.
but they're diverted out. And that's a very common, I know SafeCare has been used in that context, Triple P has been used in that context, less so parent-child interaction therapy. I know the Incredible Years has been used in that context. The nurturing model, which is a 3, they're not a 1 or a 2, they're an okay 3. So there are a class of models in there. I think one of the areas people get into trouble with is that, and again, this falls under the advice of don't be afraid to be focused, is that when you choose a parenting model, you're going to develop parenting skills. You're not going to fix the problem of poverty. You're not going to necessarily.
You're focusing on what do you want your outcomes to be.
Exactly.
You have to
So,
really
so,
define that.
so there are a class of models that have been used in those contexts, and again, I think you could, with some rooting around, you could find those on CEBC.
Any other questions?
I have a question.
Yes.
It's not really a question, but I want to address the question that you raised about data on whether programs have been shown to work in, well, the sort of the cultural competency thing. There's a fairly broad literature on these behavioral parenting programs, and generally what we're finding or what's being shown is that Jay is right. There has to be some tweaking being done. But the good news is that the core of the model can it generally holds. I think the trick is, how do you implement that in a different context? So yes, implementing any model is going to be very different in, downtown Louisville versus rural Kentucky. But the principles of the model generally have been shown to hold. So again, the data I know best are from Safe Care, statewide trial in Oklahoma. Oklahoma is very diverse. They've got two fairly metropolitan areas, Oklahoma City and Tulsa, but then most of the rest is rural. In that study, they found a nice preventive effect on Safe Care for reducing recidivism into the child welfare system. Now Safe Care was completely unadapted when it went in there. Same effects were found for whites, for blacks, and for American Indians even. And so there is some generality. I know Triple P has found the same thing. I know TFCBT, which is for child trauma. In PCIT, there was actually a study done, which is very similar to Safe Care, unadapted PCIT versus the Latino version of PCIT. I can't remember what it's called. They did the study, no difference. Both interventions were equally effective. And I think the key is, one, you've got to adapt how it's implemented to fit the context. And again, like I've said, like Jay has said, you've got to take data to make sure that you're not. When I say take data, I don't mean you've got to set up a randomized trial for every new thing you do, but you've got to take data to make sure that you're at least getting the outcomes that other studies have looked like in terms of behavior change. So, all right, that's my question.
Okay. So in terms of safe place, when you were talking instructor, do you think it ever matters, or how much does it matter, who is actually delivering, like the individual person?
Yeah, that's a great question.
And how do we all connect with different people differently.
Yeah.
And sometimes we connect with people who are more like us, and that's just the reality.
Yeah.
How do you think that, or do you find that in the safe place?
I don't know the data on that. I'm sure there is a literature on that, and that's a very good question. And the first thing that my head goes to is kind of, for lack of a better way to say it, racial matching. Does it matter, if you're a black provider serving a black family? I don't know the data on that. My guess is that it matters some, but only a little. And that's just a guess. I shouldn't even. I'm up here talking like I know what I'm talking about. But
When you think about the deliverer, if the program's accepted, it's just like a nurse. We can't choose who we take care of, but
Yeah.
just because we are a nurse, people will accept us as healthy.
Yeah.
So it's almost that kind of
Yeah.
category.
Yeah. You made me think of another thing. One thing that we always try to stress with evidence-based programs is that they are protocolized, they are manualized, and sometimes child welfare workers hate this because they think their job is to go in and assess what the crisis is and help the family deal with it, and it has to be fluid and dynamic. And no, that's just not. There are lots of comparisons in literature. That's wrong. It works much better when you go in with a specific plan. Families are happier, satisfaction is higher, caseworker satisfaction is higher, and the outcomes are better. And, think about if you went to a doctor and they said, well, how would you like me to treat you? So you're the expert. I don't care if you're looking, do what you think you need to do. And so families want that too.
And that's really critical if you're really wanting to look at longitudinal studies to be able to determine whether or not you're getting consistent results. And if
Yep.
not,
Yep.
what's the caveat there?
Exactly.
That's
Exactly.
the problem. The other thing I would just say that really kind of spoke to me when you were talking about diversity. We have to begin to think about how we're serving fathers or how we're engaging fathers
Absolutely.
in this process, because
Yep.
if we're not sending males into family situations to really engage with males, we're discriminating. I mean, we really are.
Yeah.
Because,
I think that speaks to your question. Do we have to send males, or do we just need to have to send someone that can engage males, whatever their
exactly.
Yeah.
In some way, to be able to really deliberately focus on males,
Yeah.
fathers,
Yeah.
this kind of thing.
yeah.
One thing too is interesting, like the generational gap. Like it struck me earlier. I think you said, "Hey,
The QR
ask
code.
your grandkid about." I'm like that. It's a similar thing when you think about translating a service. Like I can read a model
Yeah.
and say, "This is what this model says," and then think about how I relate that to the family. I can't go in and read from this
No.
model is going to do this, this, and this. So if I have a relationship, or if we're similar in some kind of way, I think that there's a better chance that I can kind of translate.
That's the art and the science of what we do
Yeah.
And also
together.
the worker who you choose to do the work
Yeah.
Yeah.
should have
Yeah.
some.
No matter how manualized it is, there's got to be a rapport. No rapport, forget it.
You said have courage to get rid of them. If they're not looking.
Don't tell anyone I said that. Don't-
I don't think so. Thank
Thank
you so much. And our final presenter is Dr. Kristen Valentino. Dr. Valentino is the William J. Shaw Associate Professor of Psychology at the University of Notre Dame. She's also a licensed clinical psychologist. Her research and clinical expertise is in the area of child maltreatment. Specifically, she uses a developmental psychopathology perspective to study the development of maltreated children. She focuses on the translation of developmental research into evidence-based intervention programs for maltreating families. She was the 2014 recipient of the American Psychological Association's Early Career Award for outstanding contributions to research and practice in the field of child maltreatment. And she is on the editorial board of the journal Child Maltreatment. Please welcome Dr. Valentino.
All right, great. Thank you. Thanks for inviting me to speak today. So I'm going to be speaking more specifically about some content of some approaches to preventing and intervening in child maltreatment. And so my goals are first to define what I mean when I'm talking about secondary prevention, and then to talk specifically about some relational intervention approaches. And as I review those and give a few examples of each, I'm going to think about those in terms of both brief models and long-term models, and then end with some practical considerations for implementation. Okay, so as I'm sure you're all aware, there's 3 different categories of prevention, and we generally think of primary prevention as true prevention, so it's intervening before there's a problem, before somebody has a particular disease or condition, whereas secondary prevention is really defined as reducing the impact of a disease or injury or condition early on, in very early stages of that. And the reason that we want to do this is so that we could halt or slow its progress. We want to try to, return people to their original health or function, prevent long-term problems. And so in doing that, you're going to prevent recurrence. And so as applied to child maltreatment, secondary prevention in child maltreatment refers to really getting involved in families where maltreatment has already occurred. And this also raises an interesting question because you could also think about a lot of our secondary prevention efforts as primary prevention, whether you're thinking about the family or an individual child as the unit of focus. So there's lots of families where we might get involved because an older child was substantiated as the victim in a particular instance of maltreatment, and there's lots of other siblings in the home, and if we can intervene and work with them, that's primary prevention, depending on how you're defining it. And so our goals here with secondary prevention of child maltreatment is intervening early with the goals of preventing the long-term negative outcomes associated with maltreatment and to prevent recurrence. And this is a really, really high-risk group. So we know from research over 5 years about 1 in every 2 families who are involved in the maltreatment system and child welfare system have a recurrence. So just to give a few more statistics about why this is such a high-risk group, I mean, it's more than 3 times greater the risk to be re-involved in the system compared to families who have never been involved. And research looking at, what are the risk factors that predict whether a family is going to be involved in the CPS system, and it's the single greatest risk factor is whether they've been involved previously. And we also know the risk is highest within the first year following that initiating incident. So the thing that got families involved in the first place, within that year, it's a really critical time. And as our other presenters highlighted, we know that risk is also greatest for maltreatment in early childhood. So when we are thinking about intervening, we want to intervene early, both in terms of the child's life and early in terms of when we're aware that this is a family that needs services. Because we know that early intervention is really going to lead to the most optimal outcomes. Okay, so the question is then, what do we do? And I would argue that child maltreatment should be characterized, and this is kind of a jargony term, but as a pathogenic relational experience. And the reason that I want to emphasize that is that the relationship itself is what is increasing risk for negative outcomes for the child across their lifetime, and it's also increasing risk for future maltreatment. And so we could think about maltreatment as a really extreme failure of adequate caregiving. And beyond the specific incidences of abuse and neglect, that relationship is a dysfunctional relationship that's really undermining children's ability to successfully navigate developmental tasks throughout the lifespan. And then just highlight the role of the parents in this. We know that more than 90% of families who are involved in the maltreatment system, more than 90% of child abuse and neglect occurs by one or more parents. And then, at the conclusion of services, more than 80% of those children who have been abused or neglected remain in the custody of their parents. So they're staying in these families by and large. And so in contrast to all the negative things about the parent-child relationship, there's also research that shows that positive aspects of the parent-child relationship, even in maltreating families, can buffer the effects of maltreatment on development. And that's a really important point. So we know for everybody, positive parenting is really central in scaffolding child development in multiple developing domains. Their cognitive skills, they're providing external regulation for their emotions and even their stress physiology. And so in thinking about this and the field of developmental psychopathology, for example, we often think about development as hierarchical. And so the achievement of early developmental milestones are the foundation upon which your later achievements rely. And so a positive parent-child relationship is really providing a key base. And if we can restore that in maltreating families, you're much more likely to set children on a positive developmental trajectory and reduce the potential for future maltreatment. But if this is missing, achievement of all subsequent developmental tasks are going to be more challenging. And so in doing that, we want to intervene early. And so relational interventions, they do just that. They focus on improving the parent-child relationship. And of course, the term relationship is sort of broad, so I want to highlight two specific components of the parent-child relationship that are important. And that's, I wrote maternal sensitivity, I should say caregiver sensitivity, or where, although most of the research is focused on maternal sensitivity by and large. And then also attachment organization. And so I'll explain those a little bit here. And so the formation of an attachment relationship is really a central task of the first 2 years of a child's life. The parent-child interactions throughout that time are really shaping children's behavior, their affect, and their physiological regulation. And so infants really rely on their caregiver to derive a sense of security, and then they can use this relationship in order to explore the environment. So if a child has a secure attachment to their caregiver, they have a pretty positive view of themselves and others and how others are going to react to them. They'll feel confident going out and to explore the world, in part because they know if something goes wrong or they get scared, they can go back to that caregiver and they will comfort them. And so the things that really enable a secure attachment relationship are consistent caregiver sensitivity. So that's being attuned to the child's cues, being responsive to their needs, and providing nurturance. Now, when these behaviors are absent, insecurity results. And in the case of child maltreatment, actually the parent is often the source of of the fear. So it creates a really confusing situation for young children because the very person they're supposed to be able to go to when they're scared is the source of the fear itself. And so the type of attachment pattern that tends to emerge in those situations is called disorganized attachment. And the easiest way to think about it is that they don't have a consistent or an organized pattern for dealing with stress. They don't have a consistent response like go to mom, like most kids would. And we know from the developmental psychology literature that attachment security has a huge role in supporting positive development throughout the lifespan. So there's numerous longitudinal studies showing that secure attachment is associated with emotional and behavioral functioning, coping, physiological regulation, whereas disorganized attachment is even worse than any of the other types of attachment insecurity and is really associated with maladaptation and characteristic of families that are at the highest risk for future maltreatment. And so in terms of a mechanism to focus on, attachment and sensitivity, which really go hand in hand, have a very large influence on facilitating positive developmental outcomes for maltreated children. So much work has been done attempting to modify these critical parenting behaviors, so much so that a meta-analysis recently of, well, I guess it's not that recently now, it's been about 10 years, of parenting interventions with over 80 studies of different intervention techniques that have either tried to target sensitivity or attachment organization have demonstrated that this is possible. These mechanisms are modifiable. We can improve them significantly, which is really promising. And they also examine the components of treatments that were associated with the largest effects. And so, like Dr. Whitaker was just saying, they identified that some of the brief programs actually were associated with greater effects than the longer-term programs. So being brief and more focused on specific parenting behaviors were associated with the best outcomes, leading to the question, like, is less more? Which would be fantastic from, when you're dealing with limited resources and wanting to meet the needs of lots of families. Although a criticism of that study has been that this meta-analysis involved lots of different families, and they weren't just families that have been involved in the child welfare system. But nonetheless, it's a really good way of organizing some of our thinking about different types of intervention programs, brief and long-term. So I'm just going to talk a little bit about a couple of these models. So attachment and biobehavioral catch-up, the ABC program from Mary Dozier's lab, is one of the most well-researched brief relational models. So it's on the California Clearinghouse, rated 1. And what this program does really is focus on trying to enhance caregiver sensitivity. It's trying to teach moms to be more nurturing, to follow the lead of the child. And it's an in-home intervention provided over 10 weeks. And it's been designed for children who are 6 months of age through 2 years of age, although I believe it's been tested a little bit older than that now. And it's been tested both as a primary intervention model, so for families identified at high risk but have no involvement with the DCS system yet, and as a secondary model. And they've really demonstrated improvements in attachment security, maternal sensitivity. There's also some data suggesting reduced recurrence, although that data is not using official child welfare records. But other child outcomes that have been associated with this program are emotion regulation, cognitive skills, and physiological regulation as well. So in terms of practical considerations, some of the attractive things about this model, besides it being brief, are that there's also not an educational requirement for those who are providing the intervention. So this can be done by bachelor's level individuals who are trained in the model, but they don't need to, be, for example, master's level psychologists, which potentially makes disseminating and implementing this much easier. So there's a number of other brief relational models, promoting first relationships, a brief attachment-based model by Moss and colleagues. I've also been working on one called reminiscing and emotion training. And I'm just going to talk about that briefly, not because I think it should be implemented here, because it's in the early stages of evaluation, currently in a randomized clinical trial. But just as an example of another brief intervention that's designed for children a bit older. So all of the relational interventions that I've talked about thus far, and that included in this set here, they're all conducted in the home. They're all focused on increasing sensitivity. And they all provide in-the-moment positive feedback to highlight the parent's strengths. And in fact, most of them also use video feedback. So they videotape parents practicing the things that they're trying to work on, and then they have mom watch it back, and they highlight the moments where mom did really well. And so translating this into the preschool age gets a little trickier, because during the preschool years, sensitive parenting tends to shift away from being physical displays of sensitivity to being more verbal. And so what the reminiscing and emotion training model focuses on is teaching parents how to communicate more effectively with their children about past emotional experiences. So being able to talk with children about times that they felt sad or scared or angry or happy, and being emotionally supportive in doing that. And the reason that I've been focusing on that in this intervention is that we've been able to demonstrate that maltreating mothers in particular are very poor at this skill. So they talk less with their children overall, generally, but they especially tend to avoid talking about emotions and talking about negative emotions in particular. And when you think about the emotion socialization in literature, parents have a really important role in helping kids, or needing to teach kids about their feelings, how to identify them, why they felt that way, how did they feel better. And if parents avoid talking about negative emotions, it really impedes children's developing coping skills. And so, for the reminiscing and emotion training, it's also provided in-home. I'm going to show you a tiny bit of data from our pilot study with 4 weeks of intervention. We're now testing it in a 6-week intervention in a randomized clinical trial. But again, this involves no educational requirements for the clinicians. They're all bachelor's level, and it has the potential to be cost effective. And I guess the finding that would be of most interest here is that 6 to 12 months after the intervention was completed, we found that the families who received this intervention were 3 times less likely to have had a recurrence in the Department of Child and Family Service system. But I'm going to show you some data just to highlight what I'm talking about when I later get into implementation, to think about wanting to focus on measuring the things that you think are going to change your later outcomes. So I'm focused on, in this intervention, we want to be teaching moms to be more elaborative and be more emotionally supportive. So we're teaching parents skills to ask their children questions about times they felt certain ways, giving the children opportunities to participate in that, fill in the details, and then also to be descriptive. So if the child doesn't remember, then mom can fill it in, and co-construct this dialogue. And then the emphasis really is on the feelings. So can they label emotions for children, help children understand why they felt that way, and then most importantly for the negative emotions, teaching them about how they resolve those feelings, how did they cope with them, so that they know what to do in the future when they feel that way. So our goals were first to see if we could improve moms' skills in this. So here's one slide showing some of our outcome data. So you can see all the way on the right our post-test data. There was a very big difference between the intervention and control group in mom's ability to just label negative emotions. So saying you felt sad, or I think you felt sad in that situation. Even controlling for some of the differences at pre-test, we found that after the intervention, moms were much better, much more comfortable at talking with children about their negative emotions. On the child side, we also found a much bigger difference in children's ability to label their own emotional states. And so in the emotional development literature, we know that children's ability to label their emotions and talk about their emotions is really the first step in the development of positive coping skills. They need to know how they're feeling before they know what to do with those feelings. And so post-intervention, we saw some promising effects there. And the reason that I'm showing this data is just to think about when you're selecting a model, if you think that this is the agent of change, then you need data to show that the intervention changed that. And then is that linked to the outcome that you're interested in? Okay, so some intensive relational models, probably the most researched for early childhood in terms of the long-term models is child-parent psychotherapy. And this model uses the therapist developing a relationship with the mother to model appropriate behavior and to also help moms think about how their past relationships, potentially their past traumas, are interfering with their parent-child relationship. And this model is much more intensive. It's delivered in-home weekly, typically for about a year. And so it was initially developed as an intervention to work with families where there's been domestic violence. You can see the manual up there called Don't Hit My Mommy. And it's been evaluated both as a primary and a secondary attachment model in multiple randomized clinical trials at this point, showing most significantly improvements in attachment security, which endure over a number of years, and improved maternal sensitivity. And it's also been associated with reduced trauma symptoms, improved behavior, and physiological regulation. The downside, though, is that it's pretty expensive to implement, and you need to have a master's level psychologist typically implementing that. So it's very expensive and very difficult to also learn and be supervised in, and then to bring into communities. Another long-term model is parent-child interaction therapy, and this is one of those models that came from more of the child well-being literature. So it was developed initially for children with oppositional defiant disorder or behavior problems, and it's a model that needs to be done in the lab. Typically, it's over a course of about 20 weeks, and it has two main parts. One is increasing positive parenting, and as you see this thread throughout all of the interventions, and the other is teaching specific behavioral techniques. And this model, I have a little graphic up there if you can see it. It involves needing to have a one-way mirror, and the clinician actually stands behind the mirror, and the mom has a little piece in her ear, and the clinician can coach during the session without needing to be in the room, giving mom advice or suggestions on how to implement the behavioral techniques that they've been working on. And so this was applied to child maltreatment by Chafin in 2004, and showed improvements in child behavior as expected, but also showed really significant reductions in child maltreatment. And so this is another really well-established model, but again, it can be expensive, and typically the clinicians need to be master's level psychologists. And so thinking about, how do we disseminate and implement these in the community, first I wanted to, really emphasize that it's important to be tracking progress by evaluating the mechanisms you're targeting a treatment and their associated outcomes. So in these cases, we should certainly be tracking maternal sensitivity and or attachment organization if those are the things that you expect are going to be changing and driving outcomes. And then also, you need to track recurrence, so re-involvement in the child welfare system. And of course, all clinicians are looking out for that and are mandated reporters of any suspected ongoing abuse or neglect. But just not having a new report during the intervention itself isn't really sufficient. So we need to be thinking a bit beyond that. I also wanted to highlight that I've talked a lot about the content of relational interventions, but I also want to talk a little bit about process of how they're delivered. And a really important component about how these interventions should be delivered is about providing support, both social support and also basic needs support. And so in terms of social support, many of the interventions I discussed today really focused on identifying and praising moms for specific moments when they're doing well, and not providing negative feedback or critical feedback. So kind of ignoring the moments that didn't go so well when they're learning a new skill, and really emphasizing, praising moms for the moments that did. And this is really essential, I think, in working with families involved with the DCS system, because it's essential for building trust, for building rapport, and these are moms who are being told that they are terrible at parenting. And so they're going to be very sensitive to criticism about their parenting and about their competence. Also, maltreating moms are facing multiple problems. So, typically maltreating families are having difficulties with housing, food, employment, and those struggling the most with basic needs are the most difficult to engage and retain in treatment. And then also, when these supports are removed, there's data to suggest that initial gains following brief treatments may be lost unless there can be at least some ongoing support provided, even if the treatment itself has been terminated. If there can be just a little bit more long-term supportive assistance with basic needs and case management, that can go a long way. Another promising avenue is considering group format options. There's not a ton of randomized clinical trial data available yet to determine whether these are going to be effective. And one, in fact, found some positive effects, but then on their follow-up, are the group to actually highlight that when the other services, the basic needs assistance and case management went away, then they saw a lot of their positive treatment effects falling away as well. So one model that might be promising in thinking about how can we provide all of this to families is to think about a tiered service delivery model. There's various approaches or examples of this around the country. And you could think about, more universally providing supports for basic needs, maybe some of the brief models to many, many families that you identify at risk, and then you use the time that those families are engaging in those services to identify those that might need some more intensive services. So not jumping straight to a child-parent psychotherapy or PCIT, which is going to be a year-long treatment, but start with some of the more universal brief treatments, which can be completed within 10 weeks, and then assess from there. So this way it could allow for some more targeted provision of the long-term treatment to those who need it, but enable us to use our resources in a way that affects the most people. And again, I think all these approaches can be used both as a primary or secondary prevention approach. So to summarize, I hope I convinced you that child maltreatment is a pathogenic relational problem, and so we really need to be focused on the parent-child relationship, both in prevention, primary prevention and secondary prevention, and that we have many evidence-based models that are effective at improving components of the parent-child relationship, like sensitivity and attachment organization. And so one approach that might allow us to, serve the most families with limited resources might be a tiered service delivery system that would offer more flexible and targeted provision of intensive treatments. And that is all. Any questions?
What questions do we have for Dr. Valentina? Are you sure?
All right, thank you.
Thank you so very much. Again, I really do appreciate the contributions of our presenters today. And I hope that their comments have prompted some thinking about how we might address the challenges of maltreatment here in Kentucky. I do want to remind you to please take a moment to give us your feedback on the evaluation that you all received when you arrived. And again, please use the QR code on the back if you don't have time to complete that evaluation at this time. Again, words are not adequate, really, to express my appreciation for your attendance today. Also for our legislators and their staff members, especially Senator Adams and Representative Birch for their encouragement in this doing this seminar. Appreciation to the LRC for all of their help in getting this scheduled and arranged. We appreciate the governor's office and other state organizations and state employees who have been here, and again, appreciate your attendance and hope that you have benefited. In just a few moments, we're going to provide lunch for our speakers and legislators. Lunch has been deliberately planned as an informal space, informal, private time for legislators and speakers to further their conversation about the research and the implications of the research, and to just have some private, frank discussions. So we hope that our legislators will take advantage of that opportunity to further discuss the challenges that we've been talking about today. If you would give us about 5 minutes to rearrange some things here, and if our speakers and legislators can pick up a lunch right outside the door here and then come back in here in about 5 minutes. Are there any other announcements, Nelda? Yeah, any lingering questions from anyone else? All right. Well, again, I thank you so much for attending today.